Thanks to DART, thanks to the City of Northampton for having me. My name is Ari Kriegsman, addiction medicine physician. I work at BHN in Springfield. I direct the Carlson Recovery Center, which is one of the few detox centers that we still have around for many miles, unfortunately. And I also oversee a large urban methadone program in Springfield. And my career actually has been working in homeless healthcare and in addiction. I spent 6 years working on the streets and in the shelters of San Francisco. And so it actually feels really good to work with a bunch of y'all as first responders. I think I might have some idea, maybe more than most doctors, of what your work is like. I know what it means to sort of respond and be on the streets and the kinds of things that you can see. I've also worked in addiction like across the whole spectrum. So I've worked on the streets. I'm also a primary care doctor. I've worked in the hospitals and the ER, trying to bring addiction care there. And now I oversee a detox facility and a methadone program. So I think I've hit like all the bases. And it's good to be here. And so the topic I have for today is medication treatment in the age of fentanyl. I sort of tweaked it a little bit. I think at first it was like physiology of addiction, and I didn't want to cover too much. I really wanted to sort of zero in on the thing that I'm most passionate about and share that all with you today. And this is a slide you probably are all familiar with just by nature of being in this room and probably being here today, but we're in an overdose crisis like we've never seen before. 106,000 people, 2021. And as you all probably know, this is mostly due to fentanyl. And so we really have a poisoning epidemic on top of an addiction crisis. I want to start off by we have these amazing medications. They're not perfect by any measure, but as a doctor, it's important to me that everybody knows how life-saving these can be. So this is one study from 2018 that showed that people who are on methadone compared to those who weren't had a 59% less chance of overdosing and dying. Buprenorphine or Suboxone is also really effective. They're not perfect, but in the end, if you're a doctor, the single most important outcome is keeping people alive. And as somebody who also does, I'm an internal medicine physician as well, so I can treat cancer and infectious disease and the heart and all kinds of things. And of all the medications we have across the pharmacopoeia right now, probably the medication that's keeping most people alive is Narcan and methadone. And yet it's always kind of been on the outskirts, and they're not perfect. So I don't want to stand up here and say they are. Maybe one day we'll have a cure. We don't currently. But in terms of keeping people alive, there's nothing better. This is another study which I put up maybe to make me look smart. It's busy, there's lots of numbers, but the takeaway, this is actually comparing people when they're on methadone to the times when they're off methadone. The same people. What we find here is that people when they're on methadone is about 5 times less likely to die of an overdose. That's huge. If you think about 106,000 people dying in the last 12 months we have on record. And one other thing about these statistics, these were all done in the pre-fentanyl era. We don't actually know yet how effective these are now. But if you talk to anyone who works in the systems, will say that methadone is, like the numbers are going to be even more impressive when we do know. Okay, so these are incredibly life-saving medications that we have. And yet, only 1 in 5 people with an opioid use disorder in this country is on these medications, which is striking. So what we'll cover today, this is crossed out, I don't know why, but pretend it's not crossed out. But the first piece is to talk about the pharmacology of fentanyl and really how it impacts the use of these medications right now. And I don't expect you all to walk out like as doctors or nurses, but I want to give you like a little bit of an understanding. And if I go too fast through any of this, or it feels like it's just a little too complex, just like raise a hand or something. I gave this talk to my wife this morning. She's a psychotherapist. She told me I went too fast. I'm going to try to slow that part down. But it's important to understand. There's a fentanyl I think you understand on the streets, but I want you to also understand what it means to take care of people with medications now that we have fentanyl. And the other piece I really want to cover, so 2 big topics are, the other is really how the overdose crisis has changed how we think about accessing these medications. And I think in a good way. So many people are dying that it's really incumbent on us as healthcare providers, as cities, as public health departments to do everything we can to make sure people get these medications. So that's going to be the second half of the talk. Cool, so pharmacology of fentanyl. This is probably the only pretty slide you could ever show when talking about fentanyl. These are fat cells under a microscope. And fentanyl is a drug that we use in medicine all the time. If you go and like have a colonoscopy or a rapid procedure, the great thing about fentanyl when it's used in the medical setting is it's on and it's off really fast. But when you use it chronically at high levels, it actually deposits in your fat tissue and stays there and then slowly seeps out. What we see, this is another busy slide, but the main point I want to take away is sort of shorter acting opioids. This could be like heroin or oxycodone. It used to be like 6 hours afterwards, people would reliably be in withdrawal. But fentanyl has really changed. We see a little bit of a slower onset of withdrawal. People get sick a little bit later. but then they stay sick for a long time. And it's because there's still fentanyl in their system for a really long time. And that has some implications for the medications that we have. So we have really 3 FDA-approved medications for opioid use disorder. We have naltrexone or Vivitrol, which I'm not going to talk a whole lot about today. That's a pure blocker. The reason I'm not going to focus on it is it's really hard to get people onto it. You have to be abstinent before you start it. There's also not data to show that it saves lives the same way that methadone and Suboxone do. So it leaves us with really often 99% of people are on 2 medications. And since fentanyl's come around, it's actually gotten much, much harder to use buprenorphine or Suboxone. Raise your hand if you've heard of precipitated withdrawal, just to get a sense of the room. Maybe some people are shy, or maybe nobody's heard of it. Raise your hand if you haven't heard of it. Okay, cool, that helps me. Raise your hand if you're interested in learning more about like sort of how buprenorphine or Suboxone works. All right, cool. I'm going to talk a little bit about that. And maybe this might be a little bit too, I'm going to slow it down for a sec. So buprenorphine is what's called a partial agonist. Things like heroin or fentanyl or methadone are called full agonists. So when it hits your receptor in your cell, if it's a full agonist, you get like a full effect, which could be euphoria, pain relief, right? So like those are full agonists. Now buprenorphine is what's called a partial agonist. So when it hits your receptor, you get like just some effect, but not a lot. Now for people who have an opioid use disorder, that's going to hit them enough that they just feel normal. Okay, so it's not enough to get them high. It's enough that they don't have cravings or feel withdrawal. Does that make sense? So that's what a partial agonist is. Cool? This is like, good, this is Suboxone 101, buprenorphine 101. The other really important thing to know about buprenorphine is that when it's in the system, it's like a bully. It'll like push out anything, any other opioid that's in the system, it's going to push it out of the way and take over. So if you still have heroin in your system, or methadone, or in this case, fentanyl, and remember fentanyl stays in your system a long time, if you still have some fentanyl in your system and you put buprenorphine in the system, you drop really quickly from a full agonist to a partial agonist. And when that happens, you get really sick, and it's called precipitated withdrawal. Does that make sense? Cool. So this is all coming back to fentanyl, because now that fentanyl's around, and remember how long it stays in your system, and it's variable, it's really hard to get people onto buprenorphine and Suboxone. Good, and you can get really sick. There's a picture of goosebumps. When you see goosebumps like that, you're like, damn, that person is feeling terrible. So just to make the point, while we have people dying more and more every year, if you look at a graph of prescriptions of buprenorphine or Suboxone over time, they're actually going down. It's a bummer, it's a real bummer. There's some solutions coming. I'm going to get to that, so it's not all dark, but I'm going to go through the solutions too. And I'm saying this mostly because you might meet people and you might slowly talk about medications. They might be like, I tried buprenorphine, I tried Suboxone, it just made me sick. And I want you to understand what might have happened, but also that there might be solutions that they don't know about. And you can say, just keep an open mind, go talk to a doctor, something like that. This is sort of what I hope you might take away from this talk. So, we're starting to lose this medication, the effectiveness of this medication. You see less and less prescriptions despite more and more people dying over time. Methadone's done the opposite. Methadone's actually gone up over time in the same period. And even though it used to be that there was something called an X waiver, I'm just going to move around a little bit. There used to be something called an X waiver that if you're a doctor or a nurse practitioner or a PA, you had to do like an 8 or a 24-hour training in order to prescribe Suboxone. And as recently as like 3 or 4 years ago, when like 80 or 90,000 people are dying, it's only like 3 or 4% of healthcare providers who could prescribe this life-saving medication actually did it, which was appalling. And it's a sort of a way that like stigma and addiction has always kept things over there, including within medicine. People are like, that's not my problem, that's not what I do. But you're like, people are dying of this, why is this different than anything else? And so part of the solution to that was to try to get rid of this need for the X waiver. And so they passed legislation, Biden signed it into law, anyone can now, with a DA number, can now prescribe buprenorphine or Suboxone. And despite that, we're still seeing decreases in prescriptions. One other thing just about the fat piece, and this might be especially interesting to you all who might work and do toxicologies, if any of you all are in probation or parole, because fentanyl sits in your fat tissue and then slowly seeps out over time, your toxicology for it can stay positive for a really long time, an unpredictable time. So this was a study, this sort of line shows up on a lot of them, sorry about that. But it was people were going into a 28-day residential treatment program. They were like strip searched before they went in, so they were sure as they could be that nobody was using while they were there. And what they found was even 13 days later on average, people were still testing positive for fentanyl. And there were some people in the study who completed the whole 28-day course of the treatment, and on day 28 they were still positive. and they went back out into the community. And so because it sequesters in your fat, and because people are using these really high levels, and because some of our tests are really sensitive for it, it's made actually using drug toxicology really difficult and really important, right? Because there can be really important implications of this. We actually know that pregnant women can stay positive for even longer. And then this also has implications in terms of DCF and custody and things like that. So I wanted to make sure you all were aware of just the trickiness of interpreting fentanyl drug screens in the era of fentanyl. This is a great article, if this is at all interesting to you. It's a plea from people who use drugs to clinicians, new ways to start buprenorphine are urgently needed. It was written by 2 doctors, and also Jess Tilley, who's local. I think a little whoop for her. Great, and really what they're saying is like people are dying, and like medicine, you need to move faster to figure out some way to use bupe. And so there are some things there's some newer ways to get onto this. And I don't expect you all to sort of walk out of here ready to prescribe this, but just that you're aware, so that if you meet people, because nowadays I'll meet people and I'll talk to them about buprenorphine and I'll ask them if they're interested at all, and they'll be like, no, I'm allergic to it, or no, it just makes me crazy sick. And it's actually not the buprenorphine that they're allergic to, it made them crazy sick, it's really just the fentanyl. And we just need to figure out a better way to get them onto it. And so that's a really important message. If somebody tells you I'll never take it, and be like, just go talk. They got some new options these days. And so I have 3 up here. I'll just run through. These are probably the 3 biggest ones. One's called a very low dose or microdosing. Remember, like if you have something in your system and you take buprenorphine and it kicks it all out and get crazy sick, what you do with this very low dose or microdosing is just take tiny amounts, and each day you take a little bit more. And the idea is that you slowly build it up, so you never have that big drop all at once. And so far I've had really good results with that. It still hasn't been studied in like the way that medicine likes things to be studied in these big double-blinded controlled studies. But I'll tell you that in my experience it works really well. There's more details than you all need but to know at this point, but just to say that there's this example of what it looks like. Another sort of, we have these other options called high dose or macrodosing, and it turns out like probably when somebody's starting buprenorphine, rather than giving them a little bit at a time, which is what we used to do, is just giving them a lot is the best pathway. And the third one is just to really tell you how, I want to tell you how desperate people are to start treatment. And that's why I'm going to share this one. This is not as common. It's called the quick start. But people are doing this because this is how desperate people are to get help. So they sit at home, they give themselves Narcan. And then right afterwards they take Suboxone. And so they put themselves into crazy withdrawal so that they can then sort of build back up with Suboxone. You don't have to understand all the pharmacology of this one and how it works. Just know that people are desperate enough right now, and many of you all have probably given Narcan in this room and know what people look like, right? It sucks. Like you wouldn't want to do that to yourself, but people are so desperate to get on medications that they'll do this at home and Narcan themselves so they can then get onto Suboxone. So just to share that I think the takeaways are just that there's some new ways to get onto it, and people are desperate to get onto it. This is Nora Volkow, who's the head of NIDA. This is just a little bit more of the pharmacology piece. If you're like, this is all pretty doctory for me, I promise that part's almost over. Okay. But what she's really saying is, in the era of fentanyl, we really see higher rates of tolerance and physical dependence. And so as an addiction medicine provider, we need to really adjust the way we care for people to do this. And so one of the quick things is that traditionally for Suboxone or buprenorphine, people would sometimes get limited to 16 milligrams or 24 milligrams, and insurance companies only pay for 24 milligrams. It actually turns out in the age of fentanyl, many people actually need higher doses, up to like 32 milligrams. And so we're actually running into barriers where it's hard to get people the treatment they need because insurance is still caught in an older age in terms of what they'll cover. And then similarly, methadone dosing is a big deal, right? So we're talking about fentanyl, which you all know is this incredibly potent thing, right? And for a long time, like, methadone hadn't changed in like 50 years. So there were still these regulations on how much methadone you could give on the first day, which was 30 milligrams. Okay, and this was from years and years and years ago, but meanwhile, what we have now is people using fentanyl and coming in with a tolerance. Their body's used to so much drug that there was like, many sort of providers felt like their hands were tied in terms of actually being able to dose people in terms of what they needed to get. And meanwhile, the average person who's using 2 or 3 bundles of heroin per day is going to feel really shitty and be like, what am I even doing here? It was a waste of my time. So this is a traditional piece. Just a reminder how life-saving these are. And so this incredibly life-saving medication, we were having a really hard time getting people up to good doses. Now there's good news coming too, so in case it's not all doom and gloom. So this final rule just came out, which is really like the first new final legislation in regards to methadone in like 50 years. And a lot of this was based off of what we learned during the pandemic. Okay, and so the new regulations say that we can actually start people at 50 milligrams, and if the provider who's seeing them feels that they actually need more, as the medical provider, I now have the leeway to sort of dose people more. And I see this all the time. I see people every day, if I were just to give them 30 milligrams, they wouldn't come back. Or they'd continue to use and be at risk of overdose. And so this is one of the real positive things I think that is coming out of people changing some of their minds about some of the limitations of the medications that we use. Just in some cases now I can start people at 40 milligrams, 60 milligrams, and 80 milligrams. And it's just a world of difference if you see these people. It's not for everybody, but just to say. And then this is another thing, right? People might say, I don't want to go to methadone because it's going to take me like a month or 2 months before I feel right. And that's changed. Okay, they can get feeling really like a world better in a few days. So I want you to know that message as well. So you don't have to be experts in this, but you can just say methadone is changing, and methadone really has changed. I'm going to share some more information on that. Nora Volkow again. So I think the interesting quote here, she was to say that if these medications were made universally available nationwide, opioid overdoses would fall by half, if not more. And she's a pretty conservative doctor, I'll say. We have these very effective medications, and the question is why are they not being implemented? And I'd estimate that there'd be at least 50% less people dying, and that's conservative. I think it would probably be more consequential. Imagine that, like, if we had like some cancer drugs, and it was like, yeah, if we just could get it out there more, we could save like 50,000 people's lives a year. Like, that would never happen in medicine. So you have to stop and like, why isn't this happening? Just a repeating and reminder just how effective these are. Cool. I haven't actually seen this movie. I don't know if anybody's seen it, but okay, cool. There's a couple of nods. But really what I wanted to say is, raise your hand if you've heard the nickname liquid handcuffs for methadone. Okay, you could probably, well, it's interesting with a bunch of police officers in the room, like, oh, handcuff. Like, but really that's how people feel like. They feel like they're sort of traditionally have been chained to methadone. You have to go every single day of your life. This heard Deidre Calvert, who's the head of BSAS, Bureau of Substance Abuse Addiction Services for Massachusetts. Say like she's a very high functioning, really amazing person. She's like, if I was on methadone, I couldn't make it every day. This is a map nationwide of places where you can access methadone and buprenorphine. The blue dots are the opioid treatment programs, and so there's huge swaths of this country that you have to drive for hours and hours before you can get to a methadone clinic. And if you look at Massachusetts, I just did this last night, it's kind of crude, but I think this is actually really important. The red circles, and there's no reason why some of them are bigger than others. I think I started with Great Barrington first and it was big, and then I realized it was too small, but these are the methadone clinics in Western Mass. I might have missed one or two. But you can see there's huge swaths of area where there's no methadone nearby. And remember, we sort of lost buprenorphine as treatment, or it's much harder to get people on buprenorphine. So we got 100,000 people dying nationally, maybe one medication that reliably works for everybody, or not everybody, but works for most people. And you can see there's huge areas where you'd have to drive for hours to get to it. And so that brings us to take-home bottles. And this is another thing I really want you to know, because if you're talking to somebody about getting on a life-saving treatment, they'll also be like, no way am I going to methadone every day. Like, I did that, liquid handcuffs, I don't want to do it. This is changing in a big way. And there's going to be, I don't want to stand up here and say it's all going to be great. I think the overall positivity of saving lives will be huge, but there's going to be more methadone in our streets. It's the reality. Just I want to speak frankly to a bunch of police officers, but a lot of people are going to save their lives because of it at the same time. And so traditionally, you'd had to be on methadone really for every 90 days. If all your toxicology was negative, including marijuana, you could then earn one take-home bottle and only have to come 6 times per week. Okay, that's how it was up until the pandemic. So remember, so you live, I don't know, choose a place on this map. You live here, you got to drive every single day, 360 days a year. There's a couple of holidays they give you a bottle for. Every single day. And these, in some ways, if you all think about all the clients you know who are most chaotic, right? Those are the people who might need methadone the most. They're the last person who are going to do this and get this. So it used to be 90 days you could earn one take-home bottle per week, so that after a year, maybe you only had to go 3 or 4 days a week, assuming all your toxicology was normal and your clinician did all their paperwork that they were supposed to. And this kept a lot of people out of treatment. Guaranteed I still meet people every day. Especially I used to work in the hospital in the emergency room, like, no, I don't want methadone, I won't go every day. Lots of people kept out of treatment. But this thing happened, coronavirus. And remember like social distancing, right? Well, like you don't want lots of people congregating around a methadone program every day in the morning. Like that was gonna just burn through. So very quickly, like very early in the pandemic, March 2020, BSAS and DPH came out with these regulations and gave a blanket waiver and said that anyone who's very stable could get 28 bottles off the bat. And someone who was quote unquote less stable could get up to 14. And this was up to the direction of the clinic to decide who gets what. This is huge. You can imagine the magnitude of change, right? Like all of a sudden, you know, the pandemic sucked, but all of a sudden if you lived in, I don't know, Huntington, you're like, this actually improved your life. So prior to the pandemic, only 15% of people had take-home bottles, and at the peak of the public health emergency, 52% did. September of 2023, a lot of this kept around 44%. So this is a slide again from Deidre Calvert, and basically the take-home, so this is from BSAS. High uptake of telehealth and take-home bottles. There was 0 overdose deaths from methadone during the pandemic. Better engagement in treatment, increased client satisfaction, increased provider satisfaction. So this is like really kind of like a seismic change in methadone, and I just want you all to know about that. And if I'm repeating myself, I think it's just because it's that important. Forgive me for this, it looks terrible. So I talked about the pandemic and how it changed methadone, but it also changed buprenorphine prescribing. Just real quick, when I say buprenorphine, and I should have said this a whole lot earlier in case it's been confusing for you all, what I really mean is Suboxone. Okay, Suboxone is a combination of 2 medications, buprenorphine, which is really the active ingredient, and naloxone, which is Narcan. The naloxone doesn't actually do anything for the vast, vast majority of people when you take it the proper way under your tongue. Okay, you with me so far? The reason that the naloxone is there is when buprenorphine first came out, they studied it and they found that it's actually not very pleasurable by itself when taken under the tongue, but some people might have liked it more when they crushed it and injected it. So the thought about putting the naloxone there was that you wouldn't do anything if you took it under your tongue because it's such a small dose and you don't absorb it under your tongue. But if you crushed it and inject it, then it would become active and block the effect of it. So that's like a quick primer on what Suboxone is. When I say buprenorphine, you can think of me as just speaking about Suboxone. Okay. So a big change during the pandemic was that people could get started and continued on Suboxone or buprenorphine by telemedicine, which is a big help, right? Especially it started also because we didn't want people congregating in places, but it's been proven very safe and really helped people stay engaged by being able to do it from the comfort of their own home. There's a lot of stigma in going to a clinic. There's a lot of stigma still in picking up your medications in a lot of pharmacies, unfortunately. But we do know that it helps people engage with these life-saving medications and stay in treatment. And so this has been a big step as well that came out of the pandemic and has now been finalized in the final rule. So there's a bunch of companies that have popped up and a bunch of clinics that traditionally just did it in the office that will do telemedicine. And so if that's also a barrier for some of your patients around transportation, they just don't want to go somewhere, you could just Google telemedicine buprenorphine Massachusetts. I don't want to endorse any particular program, but there's lots of companies out there that are doing that now. Cool. So I wanted to talk a little about interruptions in care. Remember that slide that I showed you about methadone and the same people with the risk of death when they're in treatment and when they're out of treatment? Like, these medications work great when you're on them, and it's really dangerous when you come off of them. And that's like often the time of the biggest risk. And I wanted to make the case that addiction is a chronic disease. This is a slide that it's probably small for you in the back, so I'll just sort of walk up for it as a way to stay moving. But really, this is like a relapse rate for people with a drug addiction. This is a relapse rate for people with type 2 diabetes, high blood pressure, asthma. So if we think of it as a chronic disease, we shouldn't blame people when they suffer or they fall off. Like, we don't blame people when their asthma is poorly controlled. If we, it's one framework for thinking about it, which is valid. And so I wanted to sort of just think next about interruptions in care and what we can do to prevent that, because that's a way to keep more people alive. One quick way to go through it is we now have these long-acting injectable forms of buprenorphine. Okay. If you ask people why they don't want buprenorphine, the 2 biggest reasons you'll hear is, one is it makes me sick, and the other is I'll just sell it. Or the third one is I hate the taste, like I can't stand the taste. And a lot of people don't know about these yet. They're still relatively new, but you can get a once-a-month injection of buprenorphine, which is really life-saving. can be really life-saving, and you don't have to worry about selling it. And the interesting thing is when you're prescribing the buprenorphine, people won't come in and tell you that. You have to meet them somewhere else, and then they tell you the truth. But we're meeting people in the hospital or in detox. It's a common thing here is, I don't want that because I just sell it. I'm like, no problem. While you're here at detox, let's get you an injection. So I want you all to know about that. But the other thing, interruptions in care, I wanted to speak to is just incarceration. I remember I was actually working in Rikers Island when this study came out. So this is in the New England Journal, the biggest journal probably in the world, medical journal. And you maybe all know this by now because there's been a lot of attention to this population, but this was 2007. And what they found was they followed people when they were first released from prison and asked the question of what's the risk of death when you first leave prison. And so of all cause of death or all cause mortality, you're like 12 or 13 times more likely to die in the first 2 weeks after you leave prison compared to someone just like you who just didn't leave prison. So it's a huge risky time. And if you specifically look at overdose death, you're like 129 times more likely to die of an overdose death just because you're in prison. So they matched it across age and other healthcare conditions that people had. So it's a hugely risky time. And I think maybe many of you all know that, but in case you didn't, if you come across somebody who just got out of jail and prison, those are the people I like to really help and go after because it's such a dangerous time. Often they've lost their tolerance by nature of being in jail or prison. This is cool, some local stuff, and all around increasing access to these medications in jail and prison. So this was actually done by Elizabeth Evans, who's at UMass Amherst, Peter Friedman, who's at Bay State. And what they actually did, this is super local, it's neat. So Franklin County Jail, my boss, Ruth Potee, is an amazing doc, and she'd been using buprenorphine from the Franklin County Jail for, I don't know, something like 5 or 6 or 7 years. And what they did was, in Hampshire County Jail, just down the road, wasn't. And so very somewhat similar communities and similar demographics, and they asked the question of people who were released from jail with an opioid use disorder, was there a different rate in terms of recidivism for those people who were prescribed buprenorphine versus those who weren't? And it was actually a drastically different rate. I think it was like something like 60-something% recidivism in Hampshire County and something like 45% in Franklin County. It was a small study, so this one didn't actually show a reduction in mortality, but there was a clear reduction in recidivism, which is something we all care about as well, right? Getting people back into society, being productive members. And this is all done locally. There's also now good data now that if you use medications like methadone and buprenorphine in jail and prisons, not only do you reduce recidivism, but you reduce the risk of overdose when they leave. And so again, just interruptions in care. And now the U.S. Attorney has announced that all correctional facilities statewide in Massachusetts need to maintain all medications for opioid use disorder. And this is still in progress. I think there's still a couple of county jails that are working on this. I haven't tracked this super closely. But soon, all jails and prisons in Massachusetts will continue these medications. And one of the interesting things about this, if you think about addiction as a chronic health condition, which it is, you can think about it as a disability, and like what other sort of disabilities would we not provide treatment for, right? Like, can you imagine if there was somebody who was in jail or prison who was a double amputee? And they're like, yeah, sorry, we don't have any ramps here. Or like, you know, so there's like provisions from the Americans with Disabilities Act to do things and take care of people. And if we think of addiction that way, as we should, then this actually took the U.S. Attorney, U.S. Attorney to sort of make sure that that actually happened in our jails and prisons. And it's for good, because it's about keeping people alive. I think this might be my last main slide. And it's a rhetorical question, but think about it for a sec. What's the right time and the right place to start addiction treatment? Just think to yourself. Always. Great, so the right time is always. And I might even just change it a little bit, like whenever someone's ready. Whenever somebody wants it. Because that's the truth, right? Not everybody wants it. Right? And so whenever somebody's ready for it, but great answer. What's the right place? Right, wherever they are. Wherever they are and whenever they're ready for it. And I think this is where medicine is going. And I think it's not getting there fast enough, but it's going there. And I just want to share a few examples of that. So wherever people are, whenever they're ready. So one is telemedicine, okay? And this is hugely expanded. We're not quite there for methadone, but you can actually do a fair amount of methadone stuff right now, telemedicine. You still have to show up in person for now to sort of get started. But for buprenorphine, you don't. And for things like medications for alcohol use disorder, which I didn't really cover today just because I didn't think I had enough time, a lot of that you can do by telemedicine as well. Okay, so the comfort of your own home. And again, you can Google telemedicine buprenorphine Massachusetts, and you'll find a whole lot of folks who you can sort of like pick up the phone, call any time of day, and get started on treatment. Hospitals. Okay, so this is a based ADR. There's some great work being done at the based ADR. So anyone who sort of lands in a hospital with an addiction issue, this was my work for 5 years, and I worked at Mercy in Springfield. And it used to be in hospitals, you get admitted with IV drug use, you had endocarditis, they would do like a $500,000 surgery for you, but nobody would actually offer you treatment for your addiction. That's how hospitals were for a long time. And they would actually say, hospitals aren't the right place to do that. And you're like, why? Wait, why? Like, because we just cracked open your sternum and did this huge heart operation, but we're not actually going to address the underlying cause. And so there's great work being done, a lot of the local emergency rooms, to start people on buprenorphine, start people on methadone, and the great part about emergency rooms is they're always open. Great, jail. So now, happy to say, great doctor, Katie Krauskopf has methadone and buprenorphine working out of the Hampshire County Jail. Tom Lincoln's doing it in the Hampden County Jail. Ruth Bote's doing it in the Franklin County Jail. And then statewide, it's really going to be a place where people, and it used to be actually, you'd meet somebody and they didn't want to start treatment because I don't want to go to jail and detox. If you ask people the worst withdrawal they've ever had, they said, I was on methadone and I went to jail. And I detoxed the worst. I'm getting some nods. But that's not the case anymore. I have Springfield CTC. There's some great people working there. There's 2 opioid treatment programs, 2 methadone programs in Springfield. BHN is one of them where I work. There's great people at CTC. And I talked a whole lot about take-home bottles, but another thing about access is you can walk into any of our clinics, either of our clinics, Monday to Friday, and get started on methadone. There's some place in the country there's like a waiting list, 2-week waiting list. You got to come these 2 days a week when our doctors are here. We're set up that you just show up any morning and you can get started. We also, both of our clinics now also have evening hours for dosing. So somebody works a job, they have to be there early in the morning, they couldn't be on methadone, no problem, we got evening doses for you now. BHN is working on a mobile methadone clinic to try to get, I might try to go real quick, yeah, okay. This is probably not a good idea, but it's too late now. Here we go, okay. So the idea of a mobile clinic is sort of like, I'm not great with my Western Mass geography, but Ware and Palmer, like right somewhere over here, right? And, or like the North Quabbin area, and there's these huge areas where methadone's needed. And so can we get a bus going to people in rural areas who are living chaotic lives and don't have transportation but want to get on methadone? So we're getting close. We were hoping to have our methadone bus already up in Ware. There's a lot of things for the DEA that they want to get right in terms of your safe and your plexiglass and safety, understandably so. So it's sort of pushed us back a little bit, but we're hoping before the summer that we'll have our mobile methadone van through BHN up in Ware, and also thinking about other places that we can go with it. EMS. And so remember when I talked about people like Narcaning themselves and then starting Suboxone? This is actually neat. It was sort of learned for the EMS people. And so folks out in New Jersey sort of thought about the pharmacology, and I won't go into the details of it, but it's hard to get onto buprenorphine right now because of fentanyl, except for right after you've been Narcaned. Is actually a good time to give it to people. So more and more, and it's not happening probably fast enough, but EMS departments in this country will they'll Narcan somebody, they'll wake up and they're like livid, and you all know what that looks like. Be like, take this Suboxone right now. And obviously they have to agree to it, but it can be a great time to start treatment as well. I don't have primary care offices on here, but primary care doctors should be able to do this. I'm a primary care doctor, and many don't, but more and more are doing it. I think there's a lot of work going into medical training right now. And it's totally reasonable to ask of your primary care doctor to get started on treatment. If they say, I can't do that, and say, why? but also, it is coming more and more. There's things like Mass Health is paying healthcare systems to make sure there's access to Suboxone and buprenorphine within primary care. And with that, I will say thank you. And I think I have plenty of time for questions. I got through 49 slides in 37 minutes. Okay, so it might be a new record. There's no such thing as a bad question. If anyone's got a question, I'd love to take one. Bring the mic to you. Oh, you want to project?
I was just going to ask about insurance regarding methadone. There was always limitations because people that qualified for 28 couldn't get them more than 14. And has that changed?
Well, couple of quick things about insurance. If you don't have insurance, you're uninsured. We have, at BHN, we have funds through the state to get started people on methadone. This brings up two good things. Let me make sure I don't want to lose your point. One is BHN, you don't need insurance. We have funds through the state to get you started. So even if like your Mass Health is pending, this is a medical emergency, come get started on treatment. The second thing that made me think of is you used to need an ID to get started on methadone. And this was to be a huge barrier. Now we've been told we need to do everything on our part as a clinic to try to get an ID, and sometimes that's trying to get jail records and getting the copy of the jail, if the people have been to jail, or sort of combing through whatever we can. We need to do our due diligence, but not having an ID is not a reason not to get started on methadone. The question about 13 or 27 bottles, I've never heard that before in terms of insurance being a limitation. So I don't want to misspeak, but I'm almost certain that that wouldn't be the case in our clinic. Yeah. Thank you.
At least for BHN, do you guys have someone to help apply for insurance if you were sent somebody with no insurance?
I wish we did. Yeah, I wish we did. We don't, but it's come up. Totally, we often will sort of send people to the hospitals, and we should, but we don't. But thank you, it's a great point. It's come up a few times recently. Yeah. But we will take them. You can get into detox, if you have no insurance, you can also go to Carlson Detox, you don't need insurance for that. We have funds from the state as well, so if people come in uninsured, these are medical emergencies. So you can get there as well. Do you want the mic back there, or can you project? Okay, great.
So my question is in the same vein, just about barriers to maybe getting this in primary care. So is it difficult for primary care doctors to get Suboxone, to order it? There are no barriers there.
So now, there's this the X waiver, so you no longer need a waiver to do it. Anyone with a DA number can do it. Honestly, the only barrier is stigma and resistance to change. Yeah. Yeah. And, unfortunately, at the same time that it's the case that you don't need this additional training, it's actually gotten harder to start, and you actually need more expertise, which is so unfortunate. But especially if, like, say, somebody used to goes to a clinic, right? Like, I got to go over here to Clean Slate to get my Suboxone, but I also have heart failure and diabetes. I see you every 2 weeks. Can't I just come here? Then it's like a no-brainer. And yeah, I mean, it's part of why I'm here talking is that you all can know this, and you heard it from a local addiction specialist who said no, and like you can spread the word, because doctors need to change and medical providers need to change, and and the younger folks are, for sure, and people are getting more trained, and we're like overloaded with students and residents who are working with us now, just because we know that change needs to happen. But there's no like administrative barrier for anybody with a DA number who can prescribe a controlled medication to prescribe buprenorphine or Suboxone. And then similarly for medications for alcohol use disorder, which I didn't touch on, but there are good ones like naltrexone or acamprosate. Sometimes we use antabuse. You don't need any specialization for that. Shame on, honestly, you hear from me, shame on medical providers who say I can't do that. In the back. Yeah, it's not my niche, so I don't want to but I will take it. Yeah, it's a really unmet need, hugely unmet need. As is pediatric mental health in general, like seeing kids in the psychiatric emergency room for days because there's not enough beds in placement. So I know that Mass Health has this sort of waivers that come out every couple of years, and they use it to sort of incentivize healthcare systems to make changes. And so the latest waiver included you could get paid more as a healthcare system if you had pediatricians who would raise their hand and say, I'm willing to prescribe buprenorphine or Suboxone out of this practice. So there's that. You can also send them to our clinic for certain. We don't see a lot of adolescents or children in our clinic, and it's tricky. I'm not actually a pediatrician, I'm an internal medicine doc, but we do have family medicine people who could see them. And it's definitely an unmet need, so thanks for speaking to that. Yeah, and I think it's going to take some, because it's also like trying to find a detox bed if you need one is a real issue. So I think we have some political representative in the room, perhaps. Other questions?
If there was a juvenile who was looking to get Suboxone or treatment, would there be any DCF implications to report maybe?
That's a great question. I wonder if there's anybody else who would be better suited to it. The question is, if there was a juvenile who was coming for treatment due to addiction, would there be cause for DCF reporting? And I think the answer often is, like, if you think about it, usually the answer is yes, but not necessarily. Like, I think you really got to think about the case and think about the risk that the child is at. And, like, you sort of sit there and, like, there's a whole different wave of risk that people can be at. But, so a couple of points. I would say probably not necessarily, but often. And I would say there's different ways to report, and, like, there's reporting to try to help people and try to get them the help that they need. But yeah, I think, depending, like, especially if you see someone who's just overdosed and it seems like there was parental negligence was involved with allowing that for some reason, maybe they found it in the house. So there's all kinds of things where it's a slam dunk. And I haven't had that scenario that often, and I have a great answer off the top of my head. I'm just sort of ad-libbing with my answer.
To admit this, and this was many years ago, I had a situation with my own child, and DCF did not get involved when we were trying to get treatment for our child. So I do think that it will be a matter of what the situation is, what was totally involved in the situation. It wasn't a parental issue in our situation, but we were trying to receive help, which I will tell you didn't happen in Massachusetts. We had to go to Connecticut, but things have changed since then. But again, it's still that desert for our young adults to get treatment in Massachusetts, so it's difficult.
Thank you. Yeah, and maybe just one sort of follow-up point. Like, I think that question is a good one. It's a really valid one, and I think I'm sort of thinking how I would answer it as a doctor versus maybe a police officer, right? And so as an addiction specialist, we're trained to sort of really have certain kinds of conversations and elicit certain kinds of information around safety. And obviously you have a whole lot of training to do that, but it's a slightly different angle. And so I just sort of say, like, it might be a different answer that I might give you as a provider versus what you might think of as a police officer. And it's obviously an important and sensitive question that you want to get right, so that's why I'm sort of like walking around it a little bit. Actually, I might go here first because we got one for a second.
Just following the theme of substance use disorder being in the lines of like diabetes or something like that, I know that for a time it was that Suboxone and methadone were like maybe a temporary solution. Are we seeing that this is going to be a lifelong?
Great question. When I think about whether or not to continue any medication, really, you're always thinking about the risks and benefits of it. You know, sometimes you'll have certain side effects with the medication, and you'll be like, is this worth it or not? And, I think when I first started training, we would say something like, people who are younger with a shorter history of addiction are going to have a better chance of coming off medications like methadone and bupe and doing well. And people who are older, who might have like a 30 or 40 year history, are going to have a less chance of being successful. The issue is this: fentanyl. It's changed the whole equation in terms of the risk-benefit when somebody comes off of it, right? Like, meaning, I totally value people who are like, I don't want this anymore. I don't want to be dependent on it. And I want to think I can get past it. And I'm through this. That was a part of my life. I'm like, I get that. I value that you feel that way. How do we reconcile that with the fact if you slip up one day, 4 months from now, and you have no tolerance, and what's being sold out there is going to kill you? And so it's a patient-centered decision. I think for me, it's really important. I want to honor the part of people that want to feel like they can get off of it. And I think they get to choose. I get to sort of put my input and sort of ask the pressing questions. And I'm always like, this is your life, and you can choose when it comes to sort of stopping medications. If you don't mind, let me just sort of poke a little bit. And so what I will say is, okay, let's do this. It sounds like you're set on getting off of it. Let's make a plan for when would be a good time to get off of it. Let's make sure the rest of your life is in order. Is your mental health in order? Is your housing in order? Are your relationships in order? Do you have good people that you can call when times are tough? Let's wait, let's work on those things and make the plan when those things are in order. And the final thing I'll say is, I didn't talk a lot about Vivitrol today, but if it's opioids, people might have an issue with either having to go frequently or the idea of being dependent on something, or like, well, what about getting on Vivitrol for 6 months or 12 months afterwards, because that's just a pure blocker. And so there's like something for protection. You don't have to, you're not really dependent on it. You can stop it without getting sick. And so that's sometimes one of the safety plans we can have. But it's a great question, and I think it gets to the heart of, we're talking about people, and everyone's different. And I think we need to honor the strengths and challenges for each person. Well, I really appreciate your attention. It's like late in the day, and you all are actually like looking at me and still listening. This is great. Thank you. Thanks for having me. It's also the first time I ever talked in Northampton, where I live, so thank you.